Good morning, everyone. I think we should probably get started. My name is Adam Sloat. I work at USAID in our Bureau for Global Health. I'm the eHealth coordinator. And it's a real pleasure for me to be introducing our Ignite Change panel. And I wanted to thank the audience as well for sticking around and postponing your lunch until after this session. We all appreciate it. As I mentioned, we do have a very exciting panel. I'm going to launch right into it. We're going to start, I'm going to make a brief introduction to each speaker in between. We're going to start with Aydoğan Özkan, who is an associate professor at the Electrical Engineering and Bioengineering departments at UCLA. And he and his group have literally won too many awards to mention, but I will mention just a couple. Presidential Early Career Award, an ARO Young Investigator Award, an NSF Award, an NIH Award, an ONR IEEE, Popular Science, Popular Mechanics, Gates Foundation, and MIT Award. So we are all expecting a lot from Aydoğan. Come on up.
Pleasure to be here and talk to you about our work on. So once again, good morning, everybody, and it's a great pleasure to talk to you about our work on the use of digital technologies for especially global health applications. So at the center of what we do at UCLA is actually the cell phone and its current state. We have more than 6 billion cell phone subscribers today, and they are being used even in the developed parts of the world. Actually, more than 70% of these cell phones are actually being deployed and used in developed parts of the world. And that connectivity, together with the current state of the art for the cell phones in terms of hardware and software, holds numerous potential and opportunities for using them for telemedicine applications. And that's exactly the theme of our lab. What you see on this slide are some of our gadgets that we utilize through the cell phone to create something that can do microscopic analysis, microanalysis, and diagnostic analysis of specimen. What you see here, which I can't point because the laser pointer is useless in this case, are microscopes, and they're integrated at the back of the cell phone with very inexpensive, lightweight, and compact designs, which literally within less than 100 grams you can carry within your pocket a microscope that can see small things like cells at a resolution level that's around a micron or so. So some of these technologies have been also licensed, and they're available for commercially available using a startup company that we launched 2 years ago. We value these components that convert cell phones into microscopes and microanalysis and diagnostic tools because they remind me the transformation from PCs to the internet, in the sense that it was the cost effectiveness of the PC that eventually led to something much bigger than the personal computer, that is the internet. And once it was small and portable and affordable by masses, it just enabled a network with that, and that was the birth to the internet, essentially. Imagine that these microscopes are deployed by all the cell phone users to increase the number of personal microscope users by several orders of magnitude within the next decade or so. That's going to enable also an amazing network that this time will connect us to not the macro world, but micro world, in the sense that we'll be able to, using our cell phones from different parts of the world, capture microscopic and nanoscopic information regarding different specimens, and that will give us a lot of data, and it's going to also create a lot of challenges because how to sort that data would be quite difficult because our digital capabilities are increasing with the Moore's Law. They're fantastically advanced these days, and it's going to get even better, even on the cell phone. However, the expert that can look at these images and sort them out is not scaling up with the digital technology, and that's a bottleneck, which is going to be a challenge for us to look at these images and characterize them. So to tackle that problem, recently we've launched an interesting project which you can also enjoy yourself by going to biogames.ee.ucla.edu. It's actually a gaming platform to test an idea that is, can we actually tap into semi-experts or minimal trained experts to create a digital super expert, especially for pathology purposes. And the goal for this case was, of course, to create a backbone, a smart framework, to look at individual decisions made by these semi-experts or minimally trained experts and create something much more powerful than the individuals making up the network. And in this particular case, we are going to be looking at malaria diagnosis using thin blood smears. And you're going to be, each gamer in this case, if you log into this website, each gamer is going to be given a microscopic image of a red blood cell, captured from different microscopes from different parts of the world. And the idea is to label them as positive or negative. The gamers are given initial training. We launched this platform in the spring of 2012, and we tested it before we launched with some undergraduates to understand how mathematically competitive this construct could be. So we tested it with something very challenging by using around 30 undergraduate students from the School of Engineering, which had no training on pathology. And they were given a very brief tutorial about the game and how it works so that they can label each cell as positive or negative. And so far, this game has been played by more than 2,000 different gamers spread around 70 different countries, which generated us 1.5 million cell diagnoses so far at the single cell level. Well, there is a nice framework behind it, which will essentially combine the decisions of individual gamers. If the gamer is randomly clicking without paying attention to the screen, there are some control images in each screen that will tell us that that decision, that gamer is randomly clicking. So we will tone down our confidence level on the decisions made by that expert. Whereas if another gamer is really doing something very well, we will also understand it through these control images, and we weigh his or her decision higher than the others, so that combine them using telecommunication tricks, that's going to enable us to create a digital super pathologist better than the best of the crowd. Essentially, it worked very nicely initially with these undergraduate students. Around 20 undergraduate students' decision collectively, once you collect them together, on more than 8,000 individual cell images, came around 1% of the accuracy of an expert who labeled the same images. So that was the initial idea, that the mathematical framework was indeed very competitive to create something useful, potentially, out of these poorly trained diagnosticians. Then, of course, our main goal here was not to create something that you can diagnose patients through undergraduate students. This was just to test the idea. But then we looked into experts who are professional diagnosticians. We've seen that. We've given them also around 8,000 images to play around using online tools that we've created. And we've seen that they disagree with each other a lot. We've given the same image, only rotated by 90 degrees, and a few hundred images later, they were disagreeing with their own decisions. So that gave us the conclusion that there is a lot of improvement that you can do at the single expert level. And if you combine, let's say, 5 or 6 experts using these algorithms, you can actually beat the best of the group and create something that is digital and that is digitally doing very well compared to the individual elements. That's also quite important for training of experts, because if these kinds of tools get better and better, we'll be creating a library of images where instead of creating a diagnostic output, we can also use that library in the same gaming platform to train people, to train pathologists, or to routinely test their training and give them concrete feedback on where they failed with a significant number of cells or pathologic images. And we've actually shown that using these around 9 experts, that we can combine them together to give a much better diagnostic output. In this plot, what you see as the green bars is the digital output of that group, and the red and blue correspond to the worst and the best of that group. So we can significantly improve the performance. And that could be quite useful, especially if you want to work with relatively poorly trained experts, so that you can rely on individuals' expertise or decision, even though they are trained, because they're poorly trained. But if you do that across 5 or 6 of them, you can get extremely competitive. So I would encourage you to actually go to this website and explore it more. You can also read some of the papers which tell you more about this, the statistical analysis of that data and how we arrive at a conclusion that is significantly better than the best of the group. So 1 minute, I'll introduce our recent project in front of this crowd, which is actually another platform which could be quite useful for looking at especially feed images of patients. So this is actually a tool which you can download yourself from BigFoodie. It's using a scanner, a flatbed scanner, to scan the images of the feed and to essentially give the user ability to track as a function of time how certain regions of the feed that they are worried or concerned about progress. And the same tool also gives you the ability to write some notes that you can share with your doctor in terms of how different parts of your feed can be getting worse or better. So it's a tool which you can use back and forth between the point of care and the home to monitor the progression of post-op patients or even diabetic patients and how their feed is evolving over time. So with this, I'd like to conclude and acknowledge our funding agencies and all the graduate students and the postdocs who are behind this work. Thank you.
Thanks, Aydoğan. That was actually extremely interesting. Next, we have Philip Ola. Dr. Ola is a professor of health informatics and is also the co-founder and president of Mobile Diagnostic Services. And today he'll be talking about low-cost medical diagnostic devices. Dr. Ola.
Hello. So my name is Dr. Philip Ola, and I'm the co-founder of Mobile Diagnostic Services. So I'm going to talk to you today about some of our innovations that we're doing in the global health market. So first off, this is a very short presentation. It's only going to be 5 minutes, so I'm going to try and cram a lot into this presentation. But first thing I need to explain to you is what we currently do. So what we do is we collaborate with startups, researchers, to basically develop appropriate and affordable low-cost point-of-care devices. So our key mission is to develop solutions that can work in the field. We currently have 2 solutions, and I use the word solutions as opposed to medical devices. One is called mClinic, and the other one is called Mobile Laboratory, or MoLab. So the mobile laboratory works on the notion of, it's a rapid diagnostic test reader. So if you don't know what those are these kind of things here, if you can see these. It's very, very similar to the pregnancy test that we use here. So we're currently using this concept to test for things like malaria, dengue fever in Nigeria and Kenya. So what we have is we have a cell phone application that works on an Android or an iOS device. And they have the capability to actually scan the test results once they're completed. The information is then transferred up to the cloud, and on the screen, the health worker is able to see what the result is straight away. One of the key concepts of our solution is that it doesn't require an attachment, because one thing that we found is very difficult to try and persuade the healthcare providers to buy additional equipment. So once the information is in the cloud, the healthcare facility has the option to actually put comments in there to say, invalid test, retest, treatment options, or do a follow-up. And that information is sent back to the handset where the patient and the community worker are, and they can actually follow up the treatment with the user. So in addition to the teleconsultation components, it also allows us to do disease monitoring and surveillance. And we also have another piece in there where if the cell phone details of the patient is collected, and there is a positive diagnosis, then the platform can also follow up with the patient based on the treatment regime that is recommended. So that's one of our solutions. The other solution is something called what we call Mobile Clinic. And what Mobile Clinic is, it's a very cheap, low-cost solution We have a proprietary phone, which we make, and we have medical devices, which are pretty dumb. It's not bad. So what happens is these devices have no power, no battery, no power source whatsoever. When you plug them into the phone, it takes the power source from the phone. This allows us to manufacture these at extremely low cost. This, for example, will be around $20. The phones are around from $40 to $60. They are typical phones. You can do SMS, you can do all the things you can do with a normal phone. We just have the software loaded onto this device. So in addition to this, we have the glucose meter, ECG, blood pressure, and the temperature. Now, these are extremely robust and, I would say, cheap. So when we developed this solution, we thought we were knocking it out of the park. This is something that a lot of people wanted. So we sent it out to a few countries to do some testing. And we were shocked by the results that we got back. As much as they love the solution, the thing that, that surprises the most is that people wanted to use their own phones. They don't like the idea that they have to purchase a phone to work with the devices. So that was a big slap in the face, because the thing that I loved the most was the phone, because the phone does so much. I mean, it's like cheap, and you can even get on the internet. It's everything. So that was a big shock, but it's very important to get that feedback. So what we did then is we're now developing a new solution, which is it's an Android-based solution that uses a hub. So we take the medical devices and we plug them into the hub, either wirelessly or with a cable, and you then can use the software on the Android phone. You put it onto the hub, and it sends the information to the Android phone from the hub. Now, the benefit of doing the hub solution is that later on it's going to be easier to integrate different medical devices without having to change things up too much. And the big thing for from the end user point of view is they can use their phones. I don't know what the fascination is with having to use your Android or your, but they will have that capability to use their own devices. Okay, and I've been told that I'm out of time, so bingo, finished. Thank you.
Wonderful. Thank you, Philip. Our next speaker is Dr. Shelley Batra, who is an Ashoka changemaker, as well as the co-founder of Operation Asha, which is India's largest non-profit organization treating tuberculosis.
Good morning, friends. I'm here to talk about Operation Asha's e-compliance initiative, used to ensure accuracy in TB treatment and to prevent MDR-TB. Now, tuberculosis is a global emergency. It's a worldwide problem, but TB is curable, fully treatable, and fully preventable. India is the emerging superpower, but 1/4 of the world's cases are in my country, and after I've spoken for 3 minutes, 2 people would have died in India. The loss of wages to the patients are more than $300 million. The loss to the economy is $23 billion per year. 100,000 women, 300,000 children discriminated against because of TB. And the biggest challenge now is of MDR-TB. Drug-resistant TB, which happens because of incomplete treatment of the basic TB, is going to be the new plague that can wipe out millions unless we act now. Well, we talk of 100% DOTS coverage in India, but according to the WHO's Stop TB group, DOTS alone is not sufficient. I'll explain what is DOTS. A TB patient is not given treatment to take at home because of the social stigma. They'll throw away the medicine, not have it, forget to swallow, etc. The patient has to go to a designated TB treatment center 60 times over 6 months, swallow the medicine in the presence of a provider. A difficult task indeed when you think of inaccessible centers located far away, and these are the times patients have to, well, choose. On one hand, they choose TB medicine, and on the other hand, there is work and wages. So obviously, they will choose food for the family. The horrifying scenario of MDR-TB is that till 2015, there'll be more than 1 million cases of MDR-TB, and where will the $16 billion come to treat them? So the issue is that we have to act now, not only to treat TB, but also to prevent drug resistance. And well, our illustrious health minister said health data in India is fudged, which created a sensation, a shameful thing to happen. What was the Operation Asha solution? So we started with community dots, empowered communities to serve their own needs, opened accessible centers, conveniently located, open early morning, late at night, so no patient has to miss work and wages in order to get the medicine. We had community members working as counselors, we trained them, and we started work in the community. But the problem then were even then still available even with the community. The primary objective of starting with the e-compliance was to ensure accuracy of treatment being done. A health worker could very well say, I have gone to a patient's house and followed up on a missing patient, but not actually done it. So how do you ensure that? Issues were of unsupervised doses, missed doses, default, fudging data, absenteeism, and time lag, and not enough tracking. The solution was a fingerprint identification. A fingerprint at the center, a fingerprint at the time of taking a dose, is indisputable evidence of patient interaction, whether it's done at the dot center or it's done remotely in the patient's home by the counselor. And a fingerprint cannot be fudged. Data entry can be fudged. The e-compliance initiative was developed with Microsoft Research and open source software. And as you can see, there are three components. There's a netbook computer, a fingerprint reader, and SMS modem. Neither hardware nor software is customized. The patients are registered by scanning a fingerprint, and at every visit, the patients scan a fingerprint. As you can see on the screen, there is minimal text. Now, we are dealing with community health workers who have a basic high school degree, barely able to read and write. So there's a very little text in Hindi and English, and there is color coding. The minute a patient logs in successfully, there is a green light and the green signal, give the medicine. Now, that is the front end. At the back end, we have the electronic medical record system. And what happens at the end of the day? If a patient misses a dose, an SMS goes to the concerned health worker and the program manager and the patient themselves. And within 24 hours, the health worker has to go to the patient's house, take the fingerprint, and repeat the patient education and give the medication. And all the data is stored at the back end in the SQL database, the electronic medical record system. We started our work in 2009, and in the initial pilot with Microsoft Research, we found our default measured at 2.5%. Now, default is the biggest challenge in TB. The government of India says 6 to 7% cases default. An independent WHO consultant says 60% cases of tuberculosis do not complete their treatment. From that, we brought it down to 2.5%. And with e-compliance, we've brought it down even further. The latest data is 1.5%. More than 2,200 patients have undergone their full treatment. 900 are undergoing treatment. More than 150,000 visits have been logged. The patient interactions have been done with the biometric. And we learned a lot, of lessons. Patients do not hesitate to give their fingerprints. There are many key benefits. There's a positive impact on the psyche of the patients. At the field level, it ensures the integrity of the work being done by the field staff. It eliminates human error. And, well, it saves their time because they do not have to generate paper reports. Management level, there's increased productivity and accuracy. And from the public health perspective, it ensures that DOTS is being done and ensures that drug resistance is halted. In spite of challenges, we've got a cost-effective program. The investment is less than $3 per patient. And we have now been invited by other NGOs and governments to roll out e-compliance. We've already started in Uganda. To conclude, technology has the power to solve the public health problems of the world. And with your support, the fight goes on. Thank you.
Thank you, Dr. Batra. I'd have to say I'm very impressed. We don't often see results on effectiveness as well as cost effectiveness as impressive as what you just presented. Our next speaker is Steve Hamel. Steve is the Associate Director of Communications and Advocacy at the World Lung Foundation. And at the foundation, Steve develops anti-tobacco campaigns in low and middle income countries. And today he'll be talking about using SMS for comprehensive tobacco control legislation.
Thanks, Adam. You'll have to excuse my notes. It's actually really hard to talk for just 5 minutes on something you're passionate about. So Tobacco is the leading cause of preventable death in the world. It causes 15,000 deaths every day, and if we do nothing, will cause more than 1 billion deaths this century. And that includes tens of millions of women and children who bear the brunt of secondhand smoking's harmful impacts. And it's a coming epidemic for low and middle income countries where there are very few barriers for tobacco companies to recruiting new smokers today, but the long-term health impacts won't be felt for years as these new smokers, who are often the primary wage earners in their families, sicken and die and overwhelm understaffed and under-resourced health systems. So happily, there is a package of evidence-based, low-cost, effective policies that will reduce tobacco use. It's endorsed by WHO. It's called the Empower Package. And my organization, World Lung Foundation, works as part of the Bloomberg Initiative on the W component, implementing public education campaigns in low and middle income countries. We've supported and advised on more than 80 campaigns in 20 countries, and more than 500 million people have seen a WLF-supported campaign. So why is social marketing so important? Well, most of the health decisions we make every day are actually informed by sources outside of the healthcare system. So like social norms, do you wash your hands after you use the bathroom, or peer influence? Are you comfortable telling a sexual partner that you want to use a condom? Or by policies, is your coworker allowed to smoke in the cubicle next to you? And sustained marketing campaigns can very quickly change social norms by reaching hundreds of millions of people that you just can't do through peer education or doctor-led education. And as important, mass media campaigns make policy interventions politically palatable by building visible public support and by building demand for new public health policies. So what is mobile's role? Well, successful social marketing boils down to two basic things at its most fundamental level. Is your message reaching your audience? Do you have reach? And mobile SMS can clearly deliver unprecedented reach, and in some rural areas even surpass television, which is tremendous. But there's scant evidence that mobile SMS is good for behavior change. Why? Well, in short, it's images and sound that convince. And marketing messages need to create emotional impact that stays with a target audience in order to motivate change. And in tobacco, we've got some really unique parallels to consider. So on the left are the ubiquitous text-only pack warnings that are informative, but studies show they have actually very little impact on smokers' habits. In the middle, you see graphic pack warnings that are being adopted in many countries and are much more effective. And of course, the gold standard for convincing are hard-hitting ads like the ones on the right that a smoker may only need to see once or twice in order to convince them to quit. And I hope you see the mobile parallels here, right? The mobile SMS is like the one on the left, the text-only message. In the middle might be like seeing a multimedia message or going on Facebook and seeing a post that a friend shared. And on the right would be more like a broadband-enabled mobile app. So we have a lot to learn from decades of social marketing and tobacco control. Now, at WLF, given the promise of mobile, but also recognizing the lack of evidence around behavior change, what we've been doing is adding mobile SMS components to communications and advocacy campaigns that happen on multiple channels. So this is the result from a 6-week campaign this year to push for smoke-free legislation in Vietnam. We incorporated a mobile and online component that allowed people who saw our campaign to sign a petition and asking Parliament to pass new legislation. We partnered with the Vietnamese Youth Union and Vinacosh, which was a coalition of in-country tobacco control groups. We sent out more than 200,000 SMS as part of our campaign. And we're still evaluating our findings, but a couple things really stick out even to us at this point. First of all, messaging really matters. We had 2 peaks of SMS push broadcast messages. And the second peak, which WLF staff rewrote the message instead of the mobile agency had much higher responses. Also, even in Vietnam and low-income countries, you'll see a multi-screen phenomenon. You see a huge peak here related to our television ads that advertised a mobile smart code. And in the long run, I think our key finding will be that unsolicited mobile SMS had unproven value as a push mechanism, especially considering that those mechanisms could have been used elsewhere. But it did prove to be a really valuable engagement mechanism, making traditional media like television, turning that into an actionable moment. When somebody sees the TV campaign or sees somebody on the air or even receives an email, they can SMS in right away and show their support. So at the end of the campaign, we had more than 5,500 advocates who pushed the campaign, and we were able to prove the law was popular, hold a press conference, and eventually the law passed. So I won't go through the takeaways, but basically, you can probably see them here. So my 5 minutes are up. Thanks so much.
Thanks, Steve. That was a great example of using social media to affect public health change at a much larger scale than most of us are used to talking about. Our next speaker is Sunnah Contreras, who is a senior health advisor for the International Community Foundation and is also a co-investigator of the Dulce Wireless Tijuana project, and she will be talking about a chronic care model for diabetes.
Good morning. On behalf of our partners, it is a pleasure to be here to show you how 3G technology is helping us to address and manage diabetes in Mexico. Our project is called Dulce Wireless Tijuana, and can I forward? Okay. And it's a randomized controlled trial in the eastern part of this city, very underserved area of the city with a lot of migration and poverty. The study is important for this region because diabetes is an epidemic in the world, and diabetes prevalence is very high. Diabetes is the #1 cause of premature disability, and it's an increasing expense for the country. The system in Tijuana and in Mexico relies on the patient visiting the clinic. And this is really a challenge for a lot of the patients that live in Tijuana, where there's a very hilly topography and the transportation is very poor. On the other hand, Mexico has one of the highest mobile penetrations, and at the same time, public health institutions have very limited tools for communicating among providers and patients, much less for monitoring diseases. So we decided to go ahead and put together design a study that would integrate known strategies or interventions that have been proven successful in similar populations on the U.S. side of the border. And we put together this design and 300 patients with 3 different groups. The maximum intervention group is the group in the middle. I know that it's hard to read, but basically it has 3 elements. The chronic care model where the nurse has an enhanced role. And we also have the peer education model where community health outreach workers are educating in the community. And we added the technology solution to this arm. The second group is the same initial 2 interventions, chronic care model, and the community outreach workers educating in the community. We are comparing the outcomes with the control group at the beginning, and then at 10 months, we're comparing metabolic indicators and also lifestyle indicators and quality of life indicators. In terms of the solution, the technology solution, this diagram shows the topology of how this works. But very simply put, we have three main types of end users. We have the patient, the provider, which is a nurse, could be nurse and doctors, and we also have the outreach workers or peer educators. The patients have access to a glucose meter and a cell phone with 3G enabled capabilities. The glucose meter, it's already a very innovative tool in this system because the public health system doesn't provide glucose meters to the patients, much less to the providers. So we're already adding something new. In terms of the providers, the providers have the same thing, the glucose meters, the cell phone with 3G, and a laptop. All of the information, the data, and the flow is centralized in a database that was customized for this study, and the database has 3G capabilities through our main carrier, Cell. What did this technology allow us to do? It allowed us to send messages and alerts to the patients. It allowed us to upload glucose readings and monitor the information. The patients are able to see videos that complement their classes. And also the patients can see handouts, and something that has been very useful is a survey that they conduct every day. It's an interactive survey that we send them, and they respond on a daily basis. And from the provider's point of view, they are able to communicate with the patients, send text messages, and communicate with each other, the providers. In terms of accomplishments, we are very excited to tell you that our public and private partnership has allowed us to overcome a lot of the challenges that we had. We've developed the technology, adopted the model. We have recruited over 240 patients as of now. And our results for the first cohorts are very promising. We're seeing decreases of 2.3 for one of the groups and 2.6 versus 0.4 in the control group, and they're all significant. Challenges, we have had a lot of challenges, and we needed to incorporate a planning phase, a pilot phase. We needed to adapt to the local and cultural differences of the many institutions that are working in this project. And finally, thank you on behalf of all the partners, and we have a booth in the exhibit on 501 if you want to see more details on this solution.
Thank you, Sonia. Our next to last speaker is Dr. Deb Van Dyke. Deb is the founder and director of Global Health Media Project. She's also a family practice clinician and a humanitarian aid worker who has worked with MSF, Doctors Without Borders, since 1993. And she'll be talking about new media approaches to providing health workers with clinical information. Deb.
Thank you, Adam. Do you hear me? Okay. To begin with, I want to point out that something that many of you are well aware of, that the lack of information among health workers is a huge issue that directly impacts the life and health of millions of people in poor countries who rely on these health workers. The stakes are very high. I had some pivotal experiences in my international work that led me to understand the teaching power of video, and to realize that video is a solution that can reach health workers in a way that nothing else really can, and the least of which is to address the literacy and language barriers. Let's see if we can push that forward. While this is a very compelling training tool, there are few videos actually tailored to developing world realities. The internet and the mobile proliferation of mobile devices nowadays can make it possible to really disseminate videos worldwide. It's kind of already scaled up in a sense. So we launched this project to design and produce video to reach health workers where they are with what they need to know in a way they can understand and remember. The videos are intended to serve as complementary training tools so they can be used in pre-service education, in-service, and also as job aids in the clinic setting. Our first video series is on newborn care. We film the videos on location in the developing world. They're all voiced over so they can be narrated in other languages. And they're simple to understand. We also do field testing among frontline workers, so we're pretty sure that they are at the level that they need to be. We create them with the end use of mobile devices in mind, so they're brief. We do a lot of close-ups, and they're formatted for mobile devices. Some will be adapted for mothers and caregivers. We'll also be producing other teaching resources such as much briefer job aids, and the footage can also be adapted for e-learning curriculums as well as use in mobile platforms. So I'm just going to show you a couple very brief clips of our videos. Because of 5 minutes, they're very brief. So go ahead and start the first one.
Stretch the skin to stabilize the vein. Keep the opening of the needle facing up. Take a shallow approach to the vein. The slight flashback of blood into the needle shows that you're in the vein. Pull the needle out gently as you push the cannula carefully forward.
Okay, and the next one is on chest indrawing, which is a newborn danger sign. Go ahead.
Stretch the skin.
No, not that one. You got it.
First, observe. The baby looks listless. His chest shows indrawing. As he draws a breath, his chest draws in, and the belly appears to move out.
Okay. Whoops. Can I go backwards? Yeah. Okay. Producing good videos is only half the battle. The second part is making sure that the videos get to those people who need them. Our first 10 videos came out several months ago, and they've now been seen in over 150 countries with more than 4,000 downloads. The downloads are mostly from staff at major training organizations like JPIGO, Save the Children, UNICEF, WHO. They've been downloaded by ministries of health, teaching institutions all over the developing world, as well as smaller NGOs. And we can do a lot better with pushing them out, but we're really focused on mostly producing at this point. So I'm going to show you another clip. It's a different kind of video. This is a behavior change communication. It's called The Story of Cholera. And it basically, hang on a second, it basically makes visible the invisible cholera germ to help people understand how cholera is transmitted and how to protect themselves. This little video has been amazingly successful. It's now narrated in 12 languages with more in the pipeline. It's gone all over the world, and it's particularly used in Haiti and in the recent cholera epidemic in West Africa. Go ahead.
We swallowed cholera germs in our water, on our food, and on our fingers. It happened so fast. By morning, my father was very sick. He had diarrhea that looked like rainwater and poured out of him.
I'm sure that whet your appetite for more. It's only 4.5 minutes, so anyway, we're producing this content, and we're seeking to integrate it into toolboxes and training curriculums so that we can expand its use worldwide. Our vision is to produce a library of high-quality video and animation on a number of important primary care topics that will be available open access in multiple languages for everyone to use. We've honed our production strategy, and we can easily accelerate the development of this content. Our most immediate need are partnerships and funding. And the last slide. We feel it's a high impact and low cost initiative, which is a best buy for global health. Thank you.
Thank you, Deb. Great work. Our last speaker is Tim Wood. Tim is the Director of Mobile Health Innovation at the Grameen Foundation. And prior to Grameen, Tim spent 12 years at Microsoft working on software development and then 2 years consulting with the Bill and Melinda Gates Foundation. Tim will be talking about the Motec suite.
Thanks, Adam. Hello, everyone. As a self-described technology geek who's been doing mobile health implementations or mobile phone-based implementations for, gosh, almost a decade now, I'm usually the one called on stage to throw cold water on people's dreams and aspirations about what it's going to take to actually do something in the field. And I'm going to try something a little bit different today and see if we can have a message of hope moving forward. For anybody who's attended the mobile health conference here for the last few years, the challenges aren't really new. The things that I've heard over the course of the last couple of days are really no different than they have been a couple of years ago, where we're faced with challenges around operability, scale, lots of pilots that end up with community health workers holding 3, 4, or 5 phones as they're trying to manage different people's pilots. And a group of us about 18 months ago started thinking about what could we do together to bring together a comprehensive suite of mobile health services that are actually working together in a coherent way to try to enable other mobile health programs to be implemented at reduced cost, at faster pace, and just with less overall overhead for the whole ecosystem. So that group has labeled itself the Motec Suite. It is a group of very experienced mobile health implementers, open source software providers, and funders who have been doing work in the field and have come together to try to bring together the technology programs that they have developed and deployed in the field and to unify them into a common platform. Everything is open source. It's available online today. A number of these programs have been operating in the field for quite some time, and we've taken a vast array of approaches towards implementing each of these programs, recognizing that every country is going to have a different set of requirements. Sometimes you can do cloud hosting, sometimes you need to host stuff in country. But we've tried to take a very pragmatic approach while simultaneously bringing together all of the experience that we have over the course of many years implementing mobile health programs. So the good news is that these organizations like Damagi and Grameen Foundation, OpenMRS, who've come together into Motec Suite, have field implementations that are in place today, operating at scale, and with information being exchanged within our complementary software programs. In Bihar, India, today, the BBC Media Action has deployed some really innovative programs around training of community health workers and some job aids. There are over 32,000 of those frontline health workers that are using these systems today. I think the adoption rates were roughly 4 times higher than anybody at the BBC anticipated. Meanwhile, CARE in Bihar is using a complementary set of services that enable frontline health workers to track patients along the continuum of care through pregnancy and the first few years of life for the child. We have a program that's been up and running in Ghana for almost 2 years now, where community health workers are tracking the progress of pregnant women, and those pregnant women are receiving IVR messages throughout the course of their pregnancy to try to change behaviors and get them to deliver in clinics, and that program continues through the first year of life, tracking the immunization status of the children that are a result of those pregnancies. Outside of the maternal health realm, Johnson & Johnson is doing a program with us in India, which is sending reminders to patients who are taking antiretrovirals for HIV/AIDS with the goal of reducing their CD4 count. And we've just finished a pilot test there, and a clinical trial is launching in just a couple of months, where the CD4 load of the patients is going to be used as the measure of the overall effectiveness of the program. And we're really excited about having some hard evidence about the promise around mobile health. World Health Partners is doing some great tuberculosis work, and World Vision just announced that they have identified a common set of functionality that they would like to see deployed across a range of 11 countries in sub-Saharan Africa, and they want to build and deploy that common set on top of Motec's suite. We're actually realizing the scale and the economies of scale that you get from designing and implementing once and deploying over the course of multiple countries. There's a whole range of services that our combined technologies bring to the table. I won't walk through all of these, but we think that it really hits the sweet spot of the vast majority of the mobile health implementations that are out there, whether or not it's sending messages via voice and IVR, collecting information with handsets, doing supply chain logistics or patient monitoring and adherence, or closing the loop with the data and delivering information back to supervisors and managers so they can track what's going on within their health systems. So there's lots more information at motecsuite.org, and we hope that you explore and take a look at that information a little more detailed. The source code is up on that site, as well as some sample videos for how the system is being used and descriptions of the projects. And our goal is over the course of the next year to bring more organizations into the ecosystem and generally speed the deployment and pace of mobile health innovations throughout the whole community. Thank you.
Thanks, Tim. We actually have plenty of time for questions, so I wanted to actually start off by giving the panelists the opportunity to ask each other questions. And let me just get it started. Feel free, everybody, to just chime in. Don't have to raise your hand. This is igniting change, so just go ahead and speak. But why don't I actually get started with Tim? So, Tim, your platform, I would say, is probably the broadest, most comprehensive. And I'm wondering, of the various tools, techniques, approaches that you've heard about from the other panelists, are there ways that you think that what they have done could be at one point integrated into a Motec platform, Motec suite type platform?
Yeah, absolutely. I'm glad you asked, because as I was sitting here listening to other presentations, I was thinking, oh, wow, we should do that too. We've already looked at the integration of diagnostic devices. We have a proof of concept that we have running in our office where you take a Bluetooth-enabled scale, drop a weight on that we pretend is a child's weight, and that scale then sends the results of the weight off to our system. We take a look at the age of the child from the medical record and their weight, and if the child is underweight, we trigger a message back to the patient that some immediate care is necessary, and perhaps to a supervisor. And we hope that a wide range of point-of-care diagnostic devices can ultimately be integrated. On the tuberculosis front, to be able to register information when someone has received their DOTS treatment and have that go into an individual's medical record, and perhaps enabling that to happen over a mobile phone as opposed to through a laptop-based device as that becomes more viable, seems incredibly promising. So the short answer is yes, and we've tried to construct stuff in a modular way so that as new innovations and technologies come to the table, we can plug things in. So we're agnostic about what type of medical record database you're using. We connect to multiple types, just as we're agnostic about the different types of devices that are used to consume data in the system.
Great, thanks. Why don't the other panelists chime in?
I think one thing that, just listening to these great presentations and the great innovations, I think that the thing that strikes me the most is how do we actually work together? Because it's great having a platform like yours and me doing what I'm doing, but what you find is when you are talking to the people on the ground, they're also talking to Motec, and what they want is they want all these things to work together from day one. So the question is there an easy process that we can come up with so that it's easy to identify what's available, so you're not reinventing the wheel? Because I think a lot of the time, everyone's trying to build the same thing without knowing what the other people are doing. So I think this is a great panel, but I think the question is, how can we leverage what we have and come up with processes so that we can work together and use each other's technology? And it's the same with the video, because I work here with Midwives for Haiti, and one thing that they want for their community workers is they want short, very low bandwidth videos that they can deploy continuously. And again, there's no one out there that is actually doing that. So again, that's something that would be ideal for what you're doing. But we have to find a way to find out about each other and to figure out how we work together.
There is a saying in the medical profession, if you have your finger on the pulse, you can identify the missing beat. And that is what innovation is all about. And there are so many innovative models that have come in the room today. There's so much energy. And I want to add that there is so much synergy in our work that it just makes sense that we move forward together. Now, one thing about technology I want to say now is that we have to be very careful where we are going to apply technology. We cannot develop technology in fancy labs and dump it on the disadvantaged. So all of us have got experience at ground level. We know what are the needs of the people, and that is how we can take our work forward. For example, Africa is a land of maybe 400 languages and 4,000 dialects. So any technology device that we have, let us think in terms of, well, low-text applications, zero-text applications, training videos, interactive videos to train community health workers. So like if Asha, we've got a training manual in Hindi and English. When we started work in Cambodia, we had to translate it into Khmer or get people who were able to understand Hindi and English. But now working in Uganda, now that is becoming a challenge. So this is why I feel that we can all work together and learn from each other, and there's so much work that needs to be accomplished.
I could not agree more with what you were saying. I just also wanted to move forward, as she said, together. We have created all these videos in diabetes, and they're targeted to using the soap opera style in Latin America that has been very popular. And I had a separate comment or question. What we are finding in our community or by deploying this solution was that people in general in the health systems or organizations are fascinating with the technology. When you ask them, do you want to collaborate, everybody says yes. But the difficulty comes when you ask the national institutions, do you want to adopt this technology? And I wanted to ask you, what strategies have you used? For us, they always go back to how much is it going to cost? And I feel that we have like ethical responsibility to make sure that if we are proposing these new technologies, we're not diverting the very few resources that the community or these governments have for these interventions versus others that maybe have more impact.
Yeah, I think in other words, you know, what's our value proposition? And as somebody who tries to convince governments to run mass media campaigns, including television campaigns, which are extremely expensive, also extremely efficient, you know, you have to develop a value proposition for the Ministry of Health to say, why should you invest in this? Where are you going to save money in the long run? It's not something that they want to put on top of what they're already doing. And that also includes thinking about how they build capacity in-house. So it's, when we talk about fundamentally changing the systems, you know, inventing the right delivery mechanism, the device is the first step, and then working with governments to build the capacity and to show the value proposition is actually a much larger problem. And then my second thought was that we have a lot of energy and science going on around the delivery mechanism for communications, and we don't have as much science going on around the content. So what types of content, what are the messaging factors that make people respond to an SMS or make an SMS effective? Is it length? Is it emotional tone? What types of content will people respond to? So there still needs to be a lot of research done in the area of content. And then, as you've been saying, that content, we should create a pool of content that everybody can draw from, whether it's videos or, you know, I know the Health Unbound library has a great tobacco control set of cessation messages. But that's what came up for me.
Yeah, I feel very excited and optimistic to hear all the higher tech solutions that are coming forth. But my own background is so out in the bush that, you know, I feel like if we could get health workers to simply recognize pneumonia by counting the respiratory rate or know what chest indrawing is, I mean, that's going to make a huge difference. And I wonder about that gap between what they need to know to do the most basic primary care kinds of things to save lives in most of the world, and then how do you train them in the higher tech approaches, and does that stick? Because not even the most rudimentary things stick for very long. So I'm curious that your experience with, training them in higher tech things, and how does that really manifest over time?
So I agree with all the other panelists' comments. The innovation landscape for global health is an ecosystem which is composed of NGOs, government, commercial entities, and academic institutions. And I represent the last one, the academic institutions. But they don't have to do all the same. And if they try to do all the same, they will fail. If I treat myself as a company or as an NGO, I'd simply fail in my academic institution. So that's why I think we got to realize early on that it's an ecosystem. It's composed of different elements to it, and we can't all expect the same things from all these key players for sustaining innovation for global health and translating it to real use. My function in the ecosystem is different than quite different than, it has to be quite different than NGOs, because I am evaluated differently, and my core reasons that I do are quite different, and the time scales are different than other institutions, other entities in this ecosystem. So we've got to realize that, and we've got to look at that as an initial feedback of how we can work together.
Great, thank you. Before I turn it over to the audience for questions, let me just quickly address Philip's point about how can we better share what we're doing. And to that end, Rockefeller Foundation over the past few months has provided funding to create a new sharing website that includes all eHealth and mHealth artifacts of every kind, so everything from source code to evaluations, PowerPoints, potentially videos and pictures. I think they actually now have the capability to upload any type of document or file. The website is www.hingx.org. It's pronounced HingeX, even though it's HingX. It's brand new. It just got out of beta. And it's actually at that point where it needs to get that critical mass of information and users in order to become the go-to site. So I'd encourage all of you to become some of the early adopters leveraging that site to better share resources going forward. And with that, let me turn it over to the audience. If you all have questions, let's go ahead and take them about 3 at a time, let's say.
Is this on? Okay.
Yep.
Hi. Hi, I'm Par Atwal. I'm a Fuld Fellow at the Johns Hopkins School of Nursing in the BSN program. And I have a question regarding MoLab. First of all, so incredibly, oh, is that? Oh, okay, sorry. Really cool. I mean, the device is so cool. I want one for myself, like for Christmas, so I could start using it on patients in Baltimore. My question is regarding the accuracy of the diagnostic ability as compared to devices we would use in the inpatient setting in a hospital here or in an OECD country. What's the accuracy level of those devices?
Let's go ahead and take a couple more questions and then have them respond.
Yeah, my question is for the professor from UCLA. Excellent work on the mobile diagnostic. Have you also looked at mobile diagnostic in terms of HIV or CD4 machines equivalents as well, and sensitivity?
My name is Rebecca. I'm a physician with Wide Horizons for Children, and my question is for Tim and Deborah. I'm curious about how you measure outcomes, particularly as you are using or working with other agencies to deploy your solution. Thanks.
Okay, why don't we give you guys a chance to answer?
Okay, I'll go first. So regarding the technology behind it, our solution is only as good as the chemical solutions that we're working with. So If these are faulty, then the good thing there is that we will be able to pick that up and do an invalid test, and then we'll be able to track the batches that are invalid. But we're not actually inventing the way the lateral flow process works. We're actually supporting it and taking the images of that back. So I think from our perspective, we have to make sure that if we're recommending certain lateral flow tests for dengue, fever, or malaria, we pick a batch or we pick a manufacturer that has some good results with it. So we're not actually re-engineering the chemical compositions of reading the test. We're just basically, using their results and sending it back.
In terms of the outcome kind of evaluation of our videos, we haven't done that yet, but we do intend to do it, and we hope to do that this year. It's very important for us to know that the videos that we're putting out actually are a learning tool where people can learn better and remember, and that they actually change their practice and even save lives. That would be a nice outcome. So we do intend to do that, perhaps through a CAP survey, knowledge, attitudes, and practice. So that's coming down the pike. But the other thing I want to say is that we are not probably going to get very involved with that over time, because I feel like it's a bit of an intuitive good. I think video is a very incredible learning tool, and I don't think we're going to spend a lot of time studying it. I come from the humanitarian aid field, and I think that you know a good thing, you get in there and you do what needs to be done, and I think there's a lot of urgency to putting out good video which has some integrity. We work with content experts, and we do field test them, so every time we do a series, I don't think we're going to end up studying it at length, but outcome studies are absolutely necessary. I just don't think that they're going to be done ad nauseum by us. Okay.
So regarding the CD4 question, we did not yet do absolute CD4 counts, but we did some work on the ratio of CD4 to CD8 ratio, lymphocyte ratio, and that can also be used as an indicator. So we created spatial surfaces that can capture specifically and sensitively from whole blood just CD4s as well as CD8s on the same disposable chip, so that you can look at the ratio of the captured CD4s to CD8. And we've seen that actually it drops significantly below unity, a couple of orders of compared to a healthy patient. So that's what we've done. But absolute CD4 count per microliter, we haven't done it yet.
And my take on outcomes, it's a great question. From a technology perspective, we're not really interested in doing technology for technology's sake. We want to see actual health outcomes at the end of the day of all of these implementations. And so it's really up to each of our implementation partners to define what health outcomes they're trying to achieve through the mobile health implementation that they're doing. For Grameen, when we are responsible for some specific implementations like we are in Ghana, we identify specific outcomes that we're looking for. For example, the rate at which women give birth with a skilled birth attendant versus giving birth at home, and we track those and measure those. But it's up to each of our implementing partners to look at the specific health outcomes. As someone who's providing technology plumbing, there's a sort of separate set of results that I'm looking for with respect to how we're serving the community that's building on top of Motec Suite. How quickly are people able to learn about the system? How quickly are they able to adapt it? How quickly can they get a product to market? And how robust is that product once it's there? I was really encouraged by a conversation I had earlier today with a group called the Drishti Partners, who have built a system on top of Motec Suite in Karnataka, India, that we had virtually zero involvement with. And they said that over the course of 2 or 3 months, they were able to grab our source code, influence stuff, and they had something up and running at a fraction of the cost that it would have taken for them to build it themselves. So from an outcome perspective, that's what I'm looking for on the technology front.
I'll talk a little bit about measurement. Now, we can measure 3 things. We can measure the input, the amount of funding going into a program. We can measure the process. This is what we have done. We've made so many videos, made so many SMSs. And the third thing we can track is the outcome metrics. Now, in Operation Asha, what we are doing, we are focusing on all 3, but the biggest impact is on outcome. What is the population served? Number of cases detected at the end of so many education programs. How many patients enrolled? How many completed treatment? How many defaulted? How many died? And the cost involved.
Thank you very much. Last two questions. We have about 3 or 4 minutes left.
Thank you. My name is Funke from Nigeria. And I think, everything that was presented was really great and very exciting to see. But my question has to do with the millions of people coming from an African background now who have very basic phones. So, phones that don't have they're not Java based, or they can't, they're not smartphones, they can't watch videos. How do we reach out to those kind of people? Because the majority of the population are actually, they fall in that category. So while the videos are good and the Motec suite is really good, how do we sort of design much more easier and simpler to use tools that can work on such basic technologies? Thank you.
Hi there. Thank you all. I'm Eric. I'm with mHealth, and I just wanted to reinforce Steve's point first, that really what I seem to be seeing is that while healthcare is largely a medical problem, health in general is very much a communications problem. And I think that seems to be at the core of a lot of what we've seen over the last couple of days. My question, though, is to do with markets and sustainability, and sort of how you're all engaging with markets and with demand to create sustainability around your programs and your services. Because a lot of times there seems to be a problem with funding, and when funding runs out, a program runs out. So how are you engaging with markets and with demands to continue your programs?
Thanks. Go ahead. Sir? Yeah.
You're right that low-end phones are definitely the most common phone that you will find in developing markets. And in addition to the prevalence of low-end phones, there's just the issue of literacy to tackle. So we've made a very heavy investment on voice interface for the mobile platform that we've built. We don't assume that someone is literate and that they are going to need to receive message based on voice in their local language. So in Ghana, for example, you can get pregnancy-related messages in one of 6 local languages. Similarly, in India, for the HIV adherence program, those calls that are calls placed to the patients to remind them with a voice message to take their medication, and then they can call into the system and use a very simple voice menu tree to navigate what symptoms they are experiencing and to find out what the best course of action would be for them to take. For community health workers that are trying to interface with the system, we've taken a multiple approach where you can have a mid-range phone or a high-end phone that has forms on it, but if you wanted to use a very low-end phone and send information into the system or retrieve information via SMS, you can do that. And that has a host of other usability challenges that come along with it, but we're deliberately agnostic about the type of device and can work from low-end phones all the way up.
Okay, I'm just going to add a little bit to that. So yes, in Nigeria we do work with a company called Hughes Allies, and what they do is they do diabetics management. So they have the glucose meter at home, and then they text in the results via SMS, which is great. But what they want to do, they want to work with us to upgrade that system, because not everybody wants to text in their results. There are people who do have better phones. So what I'm trying to say is it's important to us to focus on the lower end phones, but we shouldn't just develop our solutions for that market, because there are other emerging I'll call part of the population that do have different types of phones. So it's important for us to think ahead while we're also make sure that we do have solutions for the low-end phones. And like you said, voice XML, which is where you have the voice IVR system, those things are very easy to develop for, and they're there's a lot of them out there now that you can easily integrate. But I think the key thing is that we think about all the solutions and try not to just be SMS-centric.
I'll answer the question on sustainability, which is a very, very important question. Now, resources are limited and work is unlimited. So unless we have a low-cost, high-impact and sustainable program, the work is going to collapse. In India alone, 1 million NGOs have been registered. Hardly 500 are doing work. The rest are all just registered and seem to exist on paper. Now, one good thing in the world is that the donors are becoming very aware of the issues of high impact. There was an article in the Barron's magazine that the donor wants value for the dollar. They want a high impact program where a small amount of money is put in that gives a huge amount of leverage and where the outcome can be measured. And this is what a good program is all about. Aggressive cost cutting should be the mantra of the day. And that can be attained by various methods. And one of them is by community empowerment. And I think all of us have talked about working with the needy people. You see, when we educate them, whether it's by videos or whether by giving SMSs or training them, then we improve two issues. One issue we improve is that of accessibility. Because there's no point having fancy treatment in fancy hospitals. We have to make it accessible for the disadvantaged, because they have to earn their living. They are not going to go to a facility 20 miles away to just get some treatment done. And the second thing that helps, that works in utilizing the community is bringing down costs. Now, when I started work in Operation Asha, another NGO was using an MD physician to work as a counselor. Not only was he charging thousands of dollars a month, he was never able to reach the disadvantaged. He didn't know where Rinky lives, and there is an informal system in the bush. There is no house number, there's no road number, it's not the US. And the same thing in the slums of India. So I think we can make a program sustainable by leveraging the existing resources, whether it's given by the government, the free medicines, and then like TB treatment, poverty eradication, these are all the Millennium Development Goals. So if we work with international agencies, the USAID, the WHO, we get a lot of things for free, and the program does become sustainable on the government grants, which are minuscule, no doubt, but they do make a program sustaining if the cost is low.
I'd also like to address, I think the key to sustainability is partnering with governments, with the government in the country you're working with. I mean, ultimately, we have a lot of capacity on this stage. At World Lung Foundation, we may have the resources to go into a country and run a tobacco control campaign. But long term, the government has to apply resources to sustain that program. And even if it takes twice, 3 times as long as it often does to run a campaign, we need to have government on board. They have to be invested in the process of running that first campaign. We try and make sure that campaign is gold standard. We rigorously evaluate it, and we use that evaluation to create a value, value proposition, and to create an advocacy tool for the Ministry of Health, for instance, to go to the Ministry of Finance that say, look, we ran this great campaign, we got 100,000 people to quit smoking, that's 50,000 fewer cancer beds you're going to have to pay for in 10 years. And there was a terrific study in the 90s by Australia that showed for every dollar that they spent on tobacco control, social marketing, they saved $7 in future healthcare costs. And I think this was like a watershed moment for them. They're one of the countries that are leading in social marketing, and it's because they spent the time to rigorously evaluate, to create a value proposition, and to show that these kinds of prevention measures aren't just something that we're spending money on because we feel good about it, but because they have long-term implications. And I would say that's something that's also should be true for people in the private sector, is to partner with governments as you're creating your products, find out what the government needs are, because they're not always as market-driven as one might suspect.
I'm sorry, we're actually 5 minutes over, but I just wanted to say that I think it's in addition to government and donors, as you were saying in your concluding remarks, that we do need to identify commercially viable solutions as well, and set those aside for the private sector to invest in, and identify the needs that can really only be addressed by the public sector. And happy to speak with McCann and others further about those potential partnerships. So thank you very much to our panelists and to the audience.